excited to be kicking some of this off on local day. We're all Texans and we're all South Texans. And so we're following the theme. The other thing we all are is employers. And so I think that's an important thing to keep in mind. We're not just talking as a provider and a, and now, I'm becoming a benefits consultant, as a consultant and as a founder of a captive and an employer. We wear multiple hats here. And so we're going to be talking to you today about, different ways to pay physicians. It's a mess. I can tell you I've been working the last year and a half to try to make it better. And I feel like I'm getting there. I'm coming up with models that are really working. The other thing that I, as a physician, am passionate about is helping other physicians become and stay independent. And so, this whole theme really is going to be about that. So I'm going to start. Allison, would you introduce yourself?
Sure. I'm Allison Paoli. I'm the founder of Altiqe Consulting in San Antonio, Texas. We help employers who want to not do what they've been doing.
And Joe?
Okay, Joe LaMantia. Family owns a group of beer distributorships, and we co-founded BevCap Management with a couple of different healthcare captives.
Fantastic. So glad you all could join. And we're going to kick this off with a question that I find problematic. Given the fact that physicians entering practice are $500,000 in debt right now, how do we establish fair compensation? That's a tough one, and make independent practice appealing. And, I'm going to go from the standpoint of being, somebody who's contracting with physicians across the country, and say that when I ask independent physicians for their fair price and explain what we do and how we take work off their plate, I get a fair price 95% of the time. So I think what we do is we let physicians look at their costs, look at their overhead, look at their debt, and set their own pricing. Allison?
I would agree with that. I don't know a physician that won't take a maybe cash related payment. I don't know that they want somebody coming in with $100 bills, but an immediate payment. I think it's a problem quite often at the front desk, that there's some training issues there, and getting paid from a regular insurance company is so hard that the idea of, oh, well, we'll just pay you in 10 days is confusing, but should be less so. And then we would have more independent physicians, and I think independent physicians are very important for the health of everyday people.
Absolutely. Joe?
Okay, agree with all of that. We've started using cash pay in a number of our relationships, and that works out very well. And when you can avoid the current system, you're actually knocking off about 30% of a physician's overhead, which is an extra bonus. It works out extremely well for both parties.
I like the answer that you gave me. Was it yesterday? When what his answer to that question was, pay the doctors what they want. They're not the problem. And I think that's the best answer to that question. Okay, and then what are the current market problems with both practically and ethically paying physicians? And I'm going to wax a little long on this one because this is something that has been near and dear to my heart the last couple of years. When Green Imaging started, we were direct contracting, typically outside of a BUCA plan. The employers would pay us directly. It worked out beautifully. We started getting written into independent TPA plans, and it got super messy. And I realized all the reasons that I left traditional care, got out of insurance, started coming into my nightmares again. And, those things are, and they've gotten worse for physicians. There's several factors there. Number one is verification. You can't verify a covered member anymore because there's something called retro terminations. They're retro terminating patients. They're retro terminating plans. And so I think the patient's covered. We re-verify on the day of the exam, and yet they've been retro terminated, and it's not a covered exam. And so that's one of the things that's crept into it. Insurance subrogation. I'm not getting paid because maybe it was an accident, and it clearly wasn't an accident. I have a different diagnosis, but it is an exam that might be done after an accident. And so insurance subrogation saves down payments. And then the biggest one on my plate right now is this Zealous issue, where Zealous is charging physicians and providers across the country 5% for merchant fees on VPay cards and for 835s, which are electronic EOBs and ACH payments. 5%. That is like if you have an employee who wants electronic deposit of their payroll and a report of how that breaks down, that's like charging them 5%. So I know I'm going to repeat the question now because I went long. What are current market problems with practically and ethically paying providers?
So when you asked me this question yesterday, I think I gave you a quizzical look and said, why would there be an ethical problem? And I don't think there is, but I do think that there are a lot of practical problems. And I think we don't talk enough about what those practical problems are. And the less middle we have, the easier it is for everybody. But as an advisor, and I'm going to step on some toes now, I hear from many vendors, and they're a $1 ppm here, and they're 3% here, and they're 5% here. Well, you build 10 of those things in your health plan, and you're back where you started. Just simple. The simpler you can keep it, the better. Direct contracting, less services in the middle between the direct contractor and the payer, and then you can get back to a localized, affordable, easy healthcare system. And I sometimes think that's a pipe dream, but I know we all do it every day. Maybe we should have less band-aids to do it.
Direct contracting, I agree with you. I think that's one of the simplest mechanisms we've got out there. In certain instances, we'll set up a flat rate. We'll go in and look at the average reimbursements for a particular doctor, and if they're $100, well, we'll go ahead and pay them $125 or $150 every time somebody comes in and visits. We don't have to go through any of the gobbledygook. That's a technical term. They know what they're going to get paid. They get paid right away. It's simple, and everybody comes out ahead. One of the most critical areas in healthcare is the area of the PCP and the start of care for a particular individual, and the payment structure that they and other physicians have to deal with it's a terrible structure, to say the least. They keep getting less and less money. They're not able to do their job. When a doctor has to see 30, 40, 60 patients a day just to keep the doors open, they have a real difficult time doing their job properly. And if you can solve for that at that level, you can reduce your hospitalizations by 50%. Okay, and your specialty meds and everything else. Keep them from going to the hospital or needing the meds in the first place. Direct primary care works well for that, and a direct contract with the employer works well.
Agreed. And I'm going to talk about what has worked, what we see working in our experience in these newer health plans, and what we see not working. We come in a lot of times, we're pulled in after somebody's been on a PEPM type of imaging, discount imaging program, because it doesn't get used. It gets about 6% utilization, whereas, with some of our older clients, we're up to 75, 80% utilization in imaging. And I would say RBP is the other one, because I get the back end look at RBP. So when we're doing claims data assessments, I can look at what they paid for the exam, ultimately, with the RBP, and that's typically somewhere around what we charge. But then I get the ELAP fees or whatever the RBP, I won't do this without that, whatever that formula is for how they're paying for the RBP vendor. And frequently that payment is more than they ended up paying the provider. And that's really ugly. And so, that to me is a failed system. The other failed system is the old way of doing things where, somebody knows they may have an alternative place to go, the imaging center down the street, but their doctor tells them to go down the hall, and they're under healthcare stress, and they don't have the wherewithal, and they aren't armed to say, I've got a zero out of pocket option, please hand me that order.
I think that is a problem that we underestimate considerably. I believe that there is a lack of trust in the entire healthcare system. Insurance companies, hospital systems, brokers, employers. Employees don't trust any of these entities. They may trust their doctor. May. Now, if they have a direct primary care physician or a family physician they've been going to for a long time, that's a little bit different. But a garden variety, oh, I just found this guy, they don't trust that person either. They don't trust pharmacies. They don't trust any part of this system. So what happens is you just default to paralysis. Whatever, I just go down the hall. Or I met my deductible already, so I don't care where this comes from because the insurance will take care of it. Not realizing that that is next year's premium. And they're also afraid. I had a client who had met almost all of his very low $2,000 100% coverage plan. He needed a back surgery. The facility would not verify that he had met his deductible. They just said, you have a $2,000 deductible on this card. You owe us $2,000 or we're not going to do the surgery. Well, really? Those things happen all the time. He never said, oh, I've already met it, here it is. He never said anything. He just got very upset with the HR staff who has nothing to do with anything. And I think those are the things that we need to address. It's a holistic address, not just a specific problem, because we kind of take those as they come, right? We see them, but it's a lot of communication among us all. We had one a couple of weeks ago that we had a doctor who ordered an MRI and wouldn't give the orders. He said, call the neurologist. Well, we had the neurologist orders. We didn't have the functional medicine doctor's orders, but he was on vacation.
And they had ordered two entirely different protocols, and fortunately, she has a clinician involved in her plan. And we were able to piece together a protocol at a hospital system that suited both of them and get the exam performed. And I think it all went.
It all went fine, and the member paid nothing. The member was the CEO. And Disney says, what do you mean I need orders? Don't I just go get an MRI? Well, somebody has to say what to do. So it's a lot of moving parts, and it's a lot of communication. And until we start to have more open and honest communication about what the moving parts are, we're still going to end up back here.
Okay. And Joe, I know you've tried a lot of things. So what models have you tried that have worked, and what models are you for paying physicians? What models are you seeing are not working? You probably had as much experience and put as much thought into this as anybody.
Well, one of the models, as I mentioned earlier, is the flat rate. It's very, very simple. Most of the physicians we've approached with it like it. I think that it's really a two-way street. In order to make this work, you have to have complete transparency on the front end as well. You should know ahead of time what something is going to cost you. Ambulatory surgery centers, we utilize Texas Medical Management. All the prices are posted on the internet. That's the only bill you're going to get. I think that's important. When you deal on a direct primary care basis, you know what your charges are going to be. When you deal with contracted facilities, you know what your charges are going to be, and you're able to pay the bill in a timely fashion. And it goes really beyond that to me, and that is getting the physicians paid appropriately.
Put in and just make less. We need to look back and look at how do we pay providers, how do we pay facilities appropriately in a manner that the patient also understands.
And where the admin fees are not higher than what's being budgeted.
Yes.
All of that, just, we just need to.
But I think that also goes back to the trust conversation, is we need to rebuild that back, and I've just gotten a red flag waved at me.
Thanks, y'all. Enjoy being here.